speak on behalf of UM and what he plans to do.
So that's not easy to speak after. Well, I'm really honored to be here today, and it's a really amazing turnout, and for an amazing person and amazing family. What I'd like to talk to you guys about a little bit today, and I won't be overly wordy, is a little bit about where we are in the field of cancer research, just to put some things into perspective, and then to really quickly focus it on this disease, on amyloidosis, and a little bit about multiple myeloma, kind of a sister illness as well. As many of you know, and as several of you have commented to me as I've spoken to a few people on the way in, things are moving very quickly in the field of cancer research, but really not quickly enough for people suffering from it and for people with family members that are suffering from it. And from 80 years ago, when the infancy of chemotherapy started, and an age where all kids with acute leukemia died, to an age where 90% are cured, the era of chemotherapy, not a lot happened for the first few decades, but it seems like a ton has happened in the last decade. And you guys, many of you have seen the HBO special and talking about targeted therapy and training the immune system to fight cancer and ways to target what's wrong with the cancer cells that make them different than the healthy cells. And all of this stuff is hugely promising. And at University of Miami, we're doing a couple of cutting edge things that are in keeping with that progress. Diseases like amyloidosis sometimes get lost to the side, and part of it is its rarity, but a lot of it is lack of awareness, I think. And amyloidosis is a very insidious, difficult disease, and it's very well underdiagnosed. Many people get sick and die, and no one knows why it happened, and it was amyloidosis in retrospect. And many people, as was the case for Stephen, are diagnosed late in their course, at a time when the body is very sick, and when all the amazing new targeted treatments, it may be too late for them to offer much hope. Amyloidosis, simplistically, it's a protein disorder. We have proteins in our body that do 1,000,001 things, but when they become abnormal, they confound. I won't turn this into like a physiology lecture or anything, trust me. But when these proteins fold in an abnormal way, they turn into this waxy protein called amyloid, and they can land in the heart, and land in the kidneys, and land in the nervous system. And so what ends up happening, since it's a disease that affects multiple organs, what do we do in modern day medicine when we have a problem? We see a doctor, refers us to a specialist, and then there's some tunnel vision, right? The kidney doctor looks at the kidneys, and the heart doctor looks at the heart. But until you see the big picture, oftentimes each of those organs is pretty sick. So it's a disease where these proteins can form, and they deposit in organs, and people get sick. Well, how does it happen? Well, there's dozens of ways that it can happen, to scare anyone, but there's dozens of ways that this can happen. One way is as a sister illness to this blood cancer called multiple myeloma. This is a cancer of white cells that make antibodies. And since they're not normal white cells, the antibodies aren't normal, and the antibodies can turn into this waxy amyloid protein. And that's what happened here. There are hereditary forms of this disorder. There are disorders which occur in men as they get older for unclear reasons. And the hereditary disorders span the globe and span ethnicity and are usually underdiagnosed. To give you an example, 1 in 25 African Americans harbor a gene for hereditary amyloid. So not every one of them will develop amyloid, but there are those that will. And we see African American patients with heart failure and they never get tested. We see patients with multiple myeloma treated for myeloma, and amyloid is appreciated very late. So what can we do? Well, Romy was very accurate when she said that funding is a big challenge, because if no drug company is going to make a lot of money for a drug, there's not a lot of funding that's going to amount in profits, right? So where do we turn? We turn to the federal government, and funding from the federal government for all of cancer research has been cut back. And then we turn to philanthropy. And there are a few philanthropic organizations with a focus on amyloidosis, but they have a lot of work to do, and they're pretty small operations, and a lot more is needed. So again, I'm usually excited about Erase Amy, and I know that we can partner and do a lot of great things. And to be specific in terms of what we're working on, so everybody here can know what's going on in the backyard in South Miami. We're working on an approach with amyloidosis that really has kind of 3 fronts to it. One is awareness. So we need to educate doctors, we need to educate people how to think about this, when to think about it. The fellows, I'm one of the co-fellowship directors at UM, they're paranoid about amyloid because I'm always all over them to not miss a case. But we see patients referred from hematologists, people that are specialists in this field, with misdiagnosis and poor treatment choices. Because again, it's a rare disease. A hematologist can be in practice for 2 decades and see a handful of cases, miss many more, but diagnose a handful of cases. So one arm is awareness, and that's going to be done through lectureships and conferences where doctors come and learn about what's available in amyloid and when to think about it. Secondarily, screening. You can educate people left and right how to think about things, but having mechanisms in place where people are screened is hugely important. And you guys all know that early diagnosis is key. And you also probably know that there's not a lot of money to be made in screening, right? So money is made in novel drugs. But how do you support a training program? How do you run a study to assess whether screening helps? It's with philanthropy. So one of our efforts, and we're hopefully about to launch this, although the numbers are going to be important because we need to screen a lot of people to pick this up, is all patients with carpal tunnel syndrome are going to be, that come through the UM system, any one of the 3 major hospitals and the satellites, is going to be screened with simple blood tests for amyloidosis. Around 1 in 4 patients with amyloid will, up to 1 or 2 years prior, show up with carpal tunnel. Now, anyone who's had carpal tunnel shouldn't be worried. Carpal tunnel is hugely common. It's not here to be a fear monger. Carpal tunnel is hugely common. Amyloidosis is uncommon. However, the screening test is cheap and it's easy. And every one of those patients that shows up with heart failure and kidney failure, when they tell you, in my office, I get this all the time, I see a lot of cases, they'll tell me, oh, a year ago I had my bilateral carpal tunnel, and it always strikes me that if we had the screening program in place, those are lives saved, because the disease can be treated when people are well. When people are sick, there's huge challenges. And the final piece, and of course there's questions during or after, I'm happy to take them, but the final piece is treatment. When you diagnose amyloidosis, you can treat it. The treatment for the blood form, like Stephen had, exists. The treatment for the hereditary forms barely exists. So even when the disease is diagnosed, especially as it's typically diagnosed, which is pretty late in the course, we need more effective, more tolerable treatments because these are sick people. And you can't give sick people very toxic, strong medications. So, to kind of summarize things, amyloidosis is a rare illness, but it's an illness that has huge needs. And we can diagnose people early, and we can save people's lives, and that's not hyperbole, that's accurate. The cases that I have with the most success are people that were picked up early, some because of their own research and their own, being proactive and being their own advocate, and sometimes with doctors that know what to look for, sometimes by some good luck where the right test was ordered without knowing. And again, I could give stories after stories about local people in this area, misdiagnosed and diagnosed late. So again, there's a lot that we can do, and I think that we can be proud if our program at UM can state that we're not going to miss cases that come through our institution, and that we're going to pick, that we're not going to have patients bouncing from specialist to specialist without knowing the diagnosis, and ultimately that we're going to be a resource for all of the other doctors in this area where they can send their patients when they're concerned about this disease or who need treatment. We already are a referral area for the Caribbean islands, from South America. We see hereditary patients coming in from there. We launched a study on hereditary disease last October, and we're already the 10th highest enroller globally. So there's a pent-up need, and as we have the resources to meet that need, we can do a lot of good. So again, there's much more to say, but I know that people can only listen to a certain point before thinking about other things. So I'm happy to answer questions, and certainly I'll be around to talk to anyone personally. And just again, finally, I'm really touched, to be able to be a part of this. I wish I had known Stephen for longer, but the impression that I had in the time we had together was a very memorable one. And I feel very fortunate to be working with this family, and fortunate to be the focus in terms of these efforts and these resources. So again, thank you all for coming.